This podcast is intended as healthcare practitioner education only and is not a substitute for medical advice, diagnosis, or treatment.
These women, they present in clinic, they're in their 40s, and they come and they say that how they've been doing life, so to speak, like how they exercise and how they eat or their stress management, what have you, isn't working, if you like it used to. And then that is then impacting how they're feeling on a certain level, whether it's their mood or whether it's their energy or their weight or their gut or their stress response. So, and that's often how they commonly present. So then my interest is really about really identifying where there are imbalances that can often be overlooked or missed from the medical perspective. And when you address them, you can make such a big difference to how women feel and their quality of life.
It would be very unusual for me to see someone in clinic without the thyroid being affected in some way, because we're seeing when women aren't coming to me well and healthy and without any symptoms, So they're coming in for a reason, and the thyroid really is that master regulator.
This is Bioconcepts Between Clinical Minds, the podcast that's open-minded enough to take in all sides of a clinical story. You'll hear from researchers, doctors, naturopaths, nutritionists, and patients. We look at common clinical presentations through a different lens. It's open, frank, and sometimes controversial. Nothing is off limits. Will it change the way you treat? We'll leave that up to you. In Season 3 of Bioconcepts Between Clinical Minds, we look at thyroid health. We talk to experts in the field who will take you into their clinics and share their experience. I'm Tony Chambers, and this is Bioconcepts Between Clinical Minds. In this episode of Between Clinical Minds, we discuss the development of thyroid conditions in perimenopause with fertile ground naturopath Georgia Marrion and integrative doctor Dr Lucy Caratti. Perimenopause is a time of great change for women in many aspects, and particularly for thyroid health. Dr Lucy Caratti, an integrative GP from Perth, has built her career on helping women with their menopausal transition.
There's women that have been suffering through this time of their life for many years, and I think we've got a generation of women now going through it that are saying, no, this is not okay, I need to help myself. So I think it was a really interesting area to go into and really understand that the education we got around menopause at uni was very limited, and it was really about just managing menopause symptoms and either the use of hormones or not. But really, it's a bigger picture than that, and how we manage menopause and perimenopause really sets women up for their long-term health in terms of mental health and cardio-metabolic conditions, bone density. And so my passion just grew from there when I started realising how much there is that we can do to help women, and how, helping them through this period of life can really set them up for long-term health.
What role does the thyroid play in this? I mean, the thyroid's interesting, isn't it? Because it is impacted by so many things.
Exactly. I think it's really interesting when you look at just the thyroid by itself, and we often target just the thyroid. But really, the thyroid is really just a messenger. And there's very few cases where the thyroid is being bad or not doing what it's supposed to do. It's really responding to a whole lot of inputs. So I think that's where traditionally the thyroid has been really poorly managed. And once we start looking at why it's working that way, and not just on a whole of the T3, but really looking at each individual hormone and why it's being affected. But particularly in perimenopause, there's a few things that are going on. When you look at why the thyroid cannot behave and do what it's supposed to do, it can be because of the hormones that are changing at that time, and particularly the initial increase in estrogen blocking the thyroid hormone. But then as you get later on through perimenopause and into menopause and the lower levels of estrogen, the immune system is really affected, and that's where this remodeling of the immune system that happens during perimenopause leads you at higher risk to have any autoimmune disease, let alone just the thyroid. So there's the autoimmunity side of things, but then there's also medications and toxins and nutrient deficiencies and all these other things that can affect the thyroid, and that just increases as time goes on and as your age goes on. So it's a little bit of a perfect storm, women's 40s and then early 50s for thyroid issues to happen, whether it's autoimmune or not.
And actually that's borne out by some of the statistics that I found, in that, when you're looking at hypothyroidism in young women, so age 25, for example, it occurs about 4% of those women. Then it rises to 14 and 20% in women aged 55 and 75. And then you've got subclinical thyroid conditions in 18% of perimenopausal women. And then on top of that, you've got the antibodies detected in 25% of women aged over 65. So is that what you're seeing in your clinic, like that kind of prevalence?
Definitely. I think it is, particularly when we're in more stressful periods of our life and the effect on the adrenals, it would be very unusual for me to see someone in clinic without the thyroid being affected in some way, because we're seeing women aren't coming to me well and healthy and without any symptoms, So they're coming in for a reason, and the thyroid really is that master regulator. So there's always a role where the thyroid is being affected, and it might be in an autoimmune way, or it might be just in what, I hate the term, but the sluggish thyroid, but the non-autoimmune hypothyroidism and the subclinical hypothyroidism.
So what would be the proportion, just roughly, of the people you see or the women you see with autoimmune thyroiditis versus subclinical thyroid conditions versus, hypothyroidism?
So I'd say probably a third of women with true hypothyroidism with antibodies. Mm-hmm. Then there'd be the subclinical hypothyroidism. They have the antibodies that are elevated, but the thyroid is kind of keeping up in terms of just looking at the numbers, but patients are still feeling pretty dreadful. Then the last third is the having some kind of a thyroid presentation. Numbers aren't as optimum as we'd like, but no sign of any autoimmune markers.
Georgia Marrion is a naturopath with Melbourne's Fertile Ground Clinic, and she agrees the prevalence of hypothyroidism in this population increases.
And so for reproductive age women, it's generally around 14%, but that increases to about, up to 26 or so % in the menopausal group, which is interesting. And then even hyperthyroidism, as we say, it's a lot less prevalent. But if you compare reproductive age women versus menopausal women, it's still like say 1% versus about 5%. So you're seeing, as you say, an increase, and then that also extends to nodules, like thyroid nodules, where you tend to see it more, more commonly when, over, 45, 50 type of presentation. And you definitely see that. I see that in clinical practice a lot. And I think this is partly because, often women with overt thyroid disease, this has been identified earlier during their reproductive years, whether it's because of how it's made them feel that's driven them to seek help and that it's been hopefully addressed at that point, or what we see a lot in clinic, which is when it's picked up when they're trying to conceive and it's identified at that point. So that's, I think, part of the reason why you tend to see it more, particularly the subclinical type of thyroid issues of what we see. And it's because, as we sort of referred to in the first question, we're on the lookout for it, in this population group, because it's often overlooked. So I guess then the question is, well, why is there increased prevalence in this group? And I think prevalence figures, you've always got to take it with a grain of salt, because there's a whole, especially that we've been talking about subclinical thyroid disease, there's a lot of women that are living with it and don't know that they have it, So I think it's, if anything, it's a bit of an underestimation of what you actually see, what you see in clinical practice, and what is happening in the population.
So what's driving this increase in this age group of women?
It's interesting, this area, because there's always a combination of, well, how much of this is physiological and how much of this is pathological? And I think that's the case with any clinical assessment, right? But, when we're looking at women who are presenting with this age group and you're suspecting this thyroid issues that might be happening, obviously age is a big factor, and, even in the absence of any pathology, because, mild TSH elevations may just be a case of, what is happening with their age. So, which then comes back to what, we've always got to look at bloods in the context of the whole, not just a blood on its own. So, but it's a consideration in terms of age. Obviously, the big one is your hormone picture of what's going on. So when there's a loss of progesterone and your estrogen levels are initially going all over the place, and then eventually there's a decline, because, when we're talking about estrogen, as a function, it has an enhancing effect on thyroid levels. So then it makes sense that when there's too much or too little estrogen, it can cause problems for your thyroid, So obviously that's going to have an impact on why women are presenting with that more often. And then you're looking at things like body composition, right? We know that fat tissue adiposity is a key driver of elevating your TSH. And then when your TSH is elevated, then that has a knock-on effect, because it's a feedback system, right, on your thyroid hormones. So that alone. And, you can already see with the average woman that you might see in your 40s, these are not uncommon things that even if someone in the best of health would be presenting with, And then you're adding in stress, because your 40s is when, you've got a lot of things happening. If you've had children, more often they're at a certain age, and then your parents are getting older, and there's managing all of that, and you're juggling a lot of balls. So it's understandable that stress is a factor for a lot of these women. You see that a lot in clinical practice. And then there's your nutrient status, like a lot of your nutrients that are important for thyroid function, can be low in this age group as well. Like, obviously your obvious ones like iodine and selenium and zinc, and obviously magnesium is a big one you see in this age group in clinical practice. So I think, what you see in clinical practice is it's usually a combination of those things as far as why you're seeing it more often in this population group compared to other ones, especially, like I said, the subclinical sort of space.
So if you're, let's say subclinical, I mean, is it every kind of woman of that age that's walking in, are you testing their thyroid, or are you looking at their symptom picture? Because those symptoms can be quite generalised, can't they?
Definitely more often subclinical, for sure. And I think partly, like I sort of mentioned, it's because usually women with overt, not to say you don't see it, but usually by the time someone's in perimenopausal age, so it's picked up by them, because it makes them feel so rubbish, that they've sought out treatment and it's been addressed often. But what you can see, often when they're coming into clinic, if it hasn't been picked up before, it's a subclinical that hasn't been picked up. Or if someone's coming with overt thyroid disease, it's because they feel like what they've done to date hasn't really helped them enough. And so that's where they're often seeking out. Like they might be on thyroxine for a number of years and it hasn't really, obviously that helps with TSH to a degree, but it's not necessarily helping with a lot of the clinical symptoms, So that's often how that you'll see a lot, is that more often subclinical when it's undiagnosed. And overt that may not have been managed in a way that's making a difference for them.
Dr Caratti says the symptoms of perimenopause and those of hypothyroidism are similar.
It's really tricky, and I think patients get very confused about what's going on, and sometimes particularly for the younger perimenopausal women who that menopause hasn't really even crossed their minds, they're sure that it's just a thyroid issue that's going on, and certainly there's definitely a lot of overlap of symptoms. And then you throw in the fact that during perimenopause there's a higher prevalence of insulin resistance, which again overlaps symptoms with both thyroid disease and perimenopause. So, with perimenopause and insulin resistance, you get the weight gain and the facial hair. And with thyroid disease and insulin resistance, you get cholesterol issues. So it's this big overlapping situation. But what I have to keep coming back to with patients is that with integrative medicine, that you can't just target one thing anyway. So we can't treat the thyroid without looking at the hormones, and we can't treat the hormones without looking at the thyroid and the gut. So while it's really interesting and it can be very confusing, and patients often want a specific diagnosis of why they're feeling the way they are, it's very important to really emphasise that the diagnosis itself isn't as important, because it can be quite difficult to work out exactly what the underlying driving cause is, and we have to really look at all of it.
What, in your opinion, are the major things that are impacting the thyroid at this time? And not just the thyroid, as we mentioned, but essentially women's health at this time, from environmental toxins, etc. Like, what are the main ones that you really find are the driving factors?
So the biggest issues I find are insulin. Basically anything that's causing stress and inflammation on the nervous system. So high insulin is very inflammatory. Actual inflammation processes that are happening through the brain and through the body, and things that happen such as lower testosterone because of that's what happens after 40, and then you don't have your skeletal muscle mass. Stress, it's the adrenal health at this time is just really imperative. You can't do anything, particularly with the thyroid, but with perimenopause, you can't do anything without addressing the adrenal health. With the loss of progesterone, which is the first hormonal pattern that happens, and your progesterone is your body's chill pill, and it helps you deal with stress and have a good stress tolerance. So a lot of women find that they get quite irritable, and there's higher risk of anxiety and depression at this time based on that lower progesterone. And when your thyroid hormone is not doing what it's supposed to do, your adrenal glands often kick in to help support and produce more cortisol to give you that energy if you're tired. So if your adrenals are already shot because you've been running on fight or flight mode and in that sympathetic mode for such a long time, then your adrenals have very low reserve to kind of help out your thyroid. And in reverse, once we sort out your thyroid, often the adrenals just crash, and you get more of an adrenal insufficiency and adrenal fatigue situation. So, it's very complex, and often it's very overwhelming. But as with anything integrative health, you come back to the basics and start with the very simple things, and often that makes a really big difference to so many areas, and then we'll highlight what areas are needing a bit more focus.
Given that you are a doctor, do you prescribe progesterone to a lot of these women, or do you do it through herbs and supplements?
I do a bit of both. It depends also where in their journey they are. Are they early perimenopause? Are they particularly stressed and not going to be able to do a good supplement regime for a while? I use a lot of Vitex and a lot of those kind of supplements by themselves to boost body's progesterone. But as we're closer to late perimenopause, or actually through to menopause, there's no substitute. So we actually can use the body identical progesterone. But again, if some people have come to me and they're really at rock bottom and are desperate, then sometimes I'll start the supplements, but I'll also come over the top with the progesterone just to get that really immediate effect on the body.
The increased risk of developing cardiovascular conditions following menopause is exacerbated by the increased risk of hypothyroidism. Georgia Marrion.
Yeah, so and this is the thing, is that there's, in this age group, there is, I guess, like an interconnected dual risk with cardiovascular health, because you have the hormonal picture we mentioned with your estrogen and progesterone, and as a standalone, even in the absence of any other risk factors, that's associated with an increased risk of, cardiovascular issues, particularly like dyslipidemia, right? So then you've got that. And then there's a lot of these women that we've been talking about where they have some thyroid dysfunction or disease, and that on its own is also associated with cardiovascular issues, both hypothyroidism, and we're talking both overt and subclinical, as well as hyperthyroidism and thyroid autoimmunity, So then, and when we're seeing when there's the combination of the two, plus then the presence of risk factors for cardiovascular disease, like with BMI. Obviously, that's a really well-established one, especially when their BMI is sitting over 31. Their metabolic status in terms of their glucose and insulin regulation, obviously that's a risk factor. When we're talking about weight gain, particularly, there's also the belly fat or the visceral fat, which then further increases your risk. And then there's lifestyle factors, in terms of, if they're a smoker or if their exercise has dropped off a bit, or what their dietary intake. And again, what we touched on before, none of these are things that would be unusual to see in an average woman in their 40s as far as one or more of these risk factors. So then you've got coming back to what we touched on before, which is you've got the physiological, which is age, and then you've got the potentially, and also say like the fluctuation of estrogen and progesterone, which is normal, it's not a disease state. But then you've got the pathological in terms of, say, thyroid dysfunction and coming together and then increasing your risk and throwing in some lifestyle factors, and you can see where there's this increased risk of cardiovascular disease happening in these women.
And so how then do you approach treatment for these women? It's such a multifaceted
really is.
presentation at this age, isn't it? Well, as it is at all ages.
Yes, you're right. Yeah. But I think it's because a lot of the time it's missed. It's not attributed to it. So like I said before, women will come in and so they've had some hormone tests and they've been told that they're in perimenopause, and so they've tried hormonal treatment and it just hasn't hit it for them. So often that's when they're coming along. So I think it always comes down to proper clinical assessment in terms of initially the questions you're asking and also what you're observing about the patient. And then you're going on to doing the right tests under the right conditions for that individual, and that you're always thinking with tests, what information are you after, and therefore what do you need to do, what tests do you need to do to find that information out, and then assessing that in the context of the whole, always keeping in mind, as we touched on before, that with blood tests, obviously they're an important clinical tool, but they always need to be taken in the context of the whole. Do you know what I mean? You can never make a diagnosis just on one blood test one time. So then common tests that I'd be looking at in this type of situation is a full thyroid panel, ideally, which is not always something that you need to do that separately, because just medically they're only allowed to do TSH, and then they can only test the full panel if there's anything over 5. But, we know in clinic that anything above 2 with TSH is where we start to see some problems, potentially. So we're looking at your full thyroid panel, so your TSH, your T4 and your T3 and your various antibodies that you'd be looking at. And then I would be then looking at your various reproductive hormone ones, so your luteal phase test, so your estrogen and progesterone, and then looking at your day 2, day 3, so your FSH and LH and your androgens and your SHBG and prolactin, that type of thing. And potentially you'd also look at, depending on what you think is one of the drivers for it, is, looking at the DHEA and cortisol, and then maybe looking at the, CRP and your glucose and lipids, that type of thing. So as a basic, that's what I'd be looking at as an initial blood assessment to see, because then that's covering off your thyroid bloods, it's covering off your reproductive, the aspect of that, and it's covering off your what's happening with your adrenals type of function, and therefore how that's feeding into your reproductive. And it's also looking at, to a certain degree, your basic metabolic sort of health, which would give us a lot of information as far as what's actually happening in this woman.
So I certainly see issues with the cholesterol and hypertension, but as we said, it can be difficult to know the exact driving factor of this, because the insulin resistance can also lead to that.
Dr Lucy Caratti.
So definitely trying to reduce the complications or the risks associated with those cholesterol changes is really important. But also just understanding why things can be happening. So knowing that the LDL receptors are on the surface of the liver and they're regulated by thyroid hormones. So, if you've got low thyroid hormones, then less cholesterol is going to be taken up out of the bloodstream to be broken down. So we don't have to worry about people that are always put on statins and all these other medications. But if we know that by actually boosting up some of the thyroid hormone, that regulation will be improved, then we can do that. Also, there's a lot of interesting research with bile production and the role of bile acid in cholesterol. And we often see people with thyroid issues having a lot of digestive issues. So even just giving some bitters and some of those other herbs to really help with bile production, it helps digestion, and it also helps, using up that cholesterol in the liver, the cholesterol stores. So again, I don't worry so much about just the numbers, but working out why they're like that and really trying to just reduce some of the risks instead of just putting people on a statin.
Are there any other links between hypothyroidism and the symptoms that your patients present with?
So multifaceted. So things like the insulin resistance, but also the stress hormones, increasing your hypertension, and even just the liver metabolism. We know that when you've got higher estrogen levels, your liver's under more stress. So if it hasn't got all the nutrients it needs, then you can't metabolize the estrogen and eliminate it. So it's under more stress, and so it's going to start prioritizing what it needs to be doing. So it definitely, even by just giving the liver some of the nutrients it needs for conjugation and for all the detoxification processes, even that can help with fatty liver and the issues that we see with hypercholesterolemia. I mean, the triglycerides are really interesting as well, just with the insulin resistance, and just by reducing the complex carbohydrate in the diet and regulating the blood sugar, eating in a way that regulates your blood sugar without the peaks and troughs, and increasing protein and fats, that's been shown just to help tremendously with the triglycerides.
I mean, I know it's individual. It depends on who's sitting in front of you. But if you've got somebody with, let's say, insulin resistance, and you've got someone with a thyroid issue, what kind of diet do you necessarily ask them to follow?
It's that little juggle, isn't it, between we don't want high carbs, but women need carbs as well for your thyroid health, but also for your adrenal health. So I usually try and keep it pretty simple, and protein, really focus on a lot of protein. Women need at least 1 milligram per kilogram of protein a day, lots of good fats, and including carbohydrates, and really the education about the types of carbohydrates that women tolerate well, so including pumpkin and sweet potato. I also, for women that are very conscientious and would like to know a little bit more, we often do the continuous glucose monitoring, because I find it really interesting, the individual differences. What I might be able to have is very different to what someone else is going to have. I might eat a plum and go into a diabetic, sugar, whereas someone else can eat 5 plums and they're absolutely fine. So finding out that individual sugar response is really interesting and really can help people. I think it's also dependent on the adrenals. So if the adrenals look like they're functioning really well, then you can kind of do the 3 meals a day and try and do those little fasting periods in between, which is going to really help with the insulin resistance. But if the adrenals are struggling, we kind of have to address that first and do more regular small meals during the day to really calm the body down. And so what's good for the adrenals is not so good for the gut and for the insulin resistance, but that has to come second. So the adrenals are more important at that time. Also just looking at general inflammation and processed foods and industrial oils, and just trying to really get back to that basic fresh fruit, vegetables, and good quality protein and fats.
Do you have a time of day when it's best for them to have their carbohydrates? Because in the morning you're more insulin sensitive, but in the evening we kind of need carbohydrates to help us sleep. So what do you kind of do there?
Again, it is individual about how what they're already eating, because sometimes they're on so much bread and pasta and cakes and biscuits that having some pumpkin and sweet potato and even sort of white potato cooked and cooled every single meal is not going to be. You're still going to reduce that overload, that overall carbohydrate load. So I think it depends on what point we're coming from. But if someone's already eating pretty well, then I generally say definitely some carbs in the morning, but having a small amount of them in the evening, particularly if they're not sleeping well. If they're waking up at 2 or 3 in the morning, we explain about how that could be a hypoglycemic episode and your body waking up in response to that. So having a little bit of increasing the carbs in the evening can really help with adrenal health and your blood sugar regulation overnight.
Do you ever treat medically, or do you always treat with nutrients/herbs? And at what point do you treat for subclinical hypothyroidism?
So I guess in terms of treatment with herbs and nutrients, I always treat. It's interesting when you look at the RACGP guidelines for thyroid, and it's a nice little flow chart, and it says, measure the TSH first. If the TSH is normal, move on, don't do any further examination. So, we know that even if the TSH is normal, it doesn't necessarily mean that everything is working well. And so once you've got those T4, T3, reverse T3 and thyroid antibodies, you can get a bigger picture about what is actually going on. I do sometimes still use medication, and again, I usually try and use a combination of T4, T3. I find that gets the best outcomes for me with my patients, but you can't just do it without looking at everything else that's going on. So if the patient is really unwell, then I might give them that just to get them feeling better quicker, so we can put the energy into all those other things, because it's a lot to ask them to change the way they're eating and doing a lot of food prep and doing those things. You need to have energy and you need to have motivation. And if someone is severely lethargic and fatigued, then it's going to add more stress on them, the things that I'm asking them to change. So everything has to be a little bit of there's no ideal situation, and I might treat in one person a lot more quicker than I would with someone else with exactly the same panel, depending on their lifestyle and their symptoms. And I think that's the really important thing to remember, is not to treat. There's no perfect number in thyroid, and I might have a really happy functioning, not overweight person with one set of thyroid numbers, and then you see someone else that's overweight and sluggish and brain fog with exactly the same numbers. So you have to treat the patient in front of you. And I think that's one of the biggest problems is trying to get all the pathology in one nice little reference range, which it just doesn't happen.
Is there anything else that you're watching in the research that you haven't quite decided to use yet, that you're just kind of watching in the research for this area?
When I first started integrative medicine, I got really overwhelmed with all the areas that you could go down. But when you realise that it's all coming down to those really basic things of what we eat, how we sleep, how we breathe, how we move our body, when you think of the fact that T3 is made, 80% of it is made in the body. Only 20% is actually made in the thyroid. And a lot of it is made in skeletal muscle. So when you have sarcopenia and low muscle mass, you have low T3. It really comes down to these really basic thick pillars of health. So I do try and keep that in mind when I get a bit overexcited about different bits of research. I try and go, no, I've got to just come down to basics.
That's fascinating. I had no idea about the receptors, T3 receptors, being in skeletal muscle.
The T3 is actually produced mostly in bone and liver and muscle. And so, it's really the T4 is mostly made in the thyroid, but the majority of T3 is actually made peripherally. So that's why it's more of the thyroid is really responding to body, things that are happening in the body, not actually happening in the thyroid. But even TSH is an interesting one, with people that try and over replace to get that T3 in the right range, but then the TSH is so low. But we need TSH for the growth of the thyroid gland. So if you're over replaced for too long, then you can actually get an atrophied gland. So I do think that we focus so much on that T3 with medication, but it is each each number, the T3, the T4, the TSH, even the reverse T3, they're all telling us something, and we need to put the whole picture together. Like reverse T3 is thought of as being so bad, but we need reverse T3 to block the potential hazards of having too much T3. It's just that if it goes too high, obviously with stress and with other things that are going on, high cortisol states and inflammation, then we're not getting the effects of the T3 because it's actually blocking the T3 receptor, but also stopping making T3 being made. So each little part has its part to play, and we need to take the whole thyroid panel into account, not just the individual T3 and how that is active.
In the next episode of Between Clinical Minds, we continue the conversation, this time on autoimmune thyroid conditions, with specialist thyroid naturopath Tara Nelson, integrative GP Dr Amita Gajjar, and Graves' disease patient Byron Pugh. Thank you for listening. We hope this podcast engaged and empowered you. And thank you to all of our experts. You can read more information on each of them on our website, bioconceptsengage.com.au. If you enjoyed this episode of Between Clinical Minds, please refer a friend and share the love. To continue the conversation, you can contact us at bioconceptsengage.com.au, where community is more than a concept.